Me and my colleagues have established this presentation about osteomyelitis, and we will start to present it. These are our objectives. I'll be talking about the definition of osteomyelitis, and I will mention the risk factor of osteomyelitis, and I will outline the common organism associated with osteomyelitis. Then my colleague Salman will outline the pathophysiology of osteomyelitis, and then the classification of osteomyelitis is done by my colleague Abdullah. The clinical presentation is done by my colleague Watan, and the diagnosis and management of osteomyelitis is by my colleague Ali Al. When we start to talk about osteomyelitis, we will start with the definition. There are a lot of definitions actually, and it's a broad term that explains that it's the infection of the bone and bone marrow, or in some other references, it's called as stated as the infection of bone with progressive inflammatory destruction and apposition of new bone. So there is inflammation and reconstruction of bone. If we want to see here, inflammation of the bone marrow, and also the trabeculae of bone and even the cortex in some cases. And in the left picture, we can see a histopathological slide showing the inflammatory infiltrate around the trabeculae with disruption of the normal osteocyte and the osteoblasts. We can see here that they are mostly neutrophil and polymorph. So this is an acute inflammation. The most common causative organism, we have Staph aureus or Staphylococcus aureus. It's the most common overall, representing 80 or 90% of all infections. Then there are some opportunistic or some conditional cases of E. coli and Pseudomonas aeruginosa and Klebsiella species. They are mostly seen in IV drug abusers and as a complication of genitourinary tract infection. Salmonella is very common to be seen in sickle cell disease. And when we come to Haemophilus influenzae and Group B strep, they are seen in neonate infections or neonate osteomyelitis. This may help us in deciding on the individual therapy and in the management itself. When we go for the risk factors, we have multiple risk factors, and I will explain some of them. Recent trauma or surgery, it's common sense that when there is a lesion in the bone, either an open fracture or trauma to the bone, there will be a decrease in the normal structure and normal defense mechanism, like the cortical bone being so hard and preventive of infection. Immunocompromised patient, it's common sense also because it's decrease in any type of immunity will lead to infection of any kind. Illicit IV drug users, they introduce organisms that are pathological to the bone itself and to other parts of their body. Systemic conditions like diabetes mellitus and sickle cell, poor vascular supply, and peripheral neuropathy. I'll be talking about these now. When we talk about illicit IV drug use, it introduces mostly Pseudomonas aeruginosa from the skin to the bone and to the whole body, actually. We can see also Staph epi in arthroplastic patient or a patient with artificial joints. Diabetes and sickle cell disease both inhibit immunity and cause poor vascular supply and neurosupply, which decrease further immunity. Poor vascular supply itself causes transient immunocompromise and delay inflammation process and healing, which will promote infection of the bone. For peripheral neuropathy, it increases susceptibility to trauma and decreases identification of trauma in the patient himself. Peripheral neuropathy also delays healing together with poor vascular supply. Now I've finished my talk. My colleague Salman will start with pathophysiology.
Thank you, Abdullah. Can I have the pointer or the presenter so I can control? Okay. Assalamu alaikum.
Perfect.
Hello, everyone. My name
Yes.
is Salman, and I'm going to talk about the pathophysiology of osteomyelitis. So first, we need to know that how does the infection reach its bone? We have three main mechanisms, which first one is the hematogenous, which means basically through the blood vessels, and this is the most common type in pediatric population or in children. In case of child or skeletally immature, the hematogenous spread will eventually end in the metaphysis of long bones. And if it's occur in adults, most likely it's going to be in the vertebral bodies. This is for the hematogenous, and the most common organism that cause hematogenous spread, it's the Staph aureus. The second type, we have the contiguous contamination, and this can be either through direct inoculation or direct implantation of pathogen, or from surrounding tissue and joint. Sometimes, if we have a abscess or pathogen in the surrounding muscle of the bone, we can the infection can spread from the muscle into the bone, and also if it's in the joint, which we call it the septic arthritis, sometimes can be complicated by osteomyelitis. And for the direct implantation of pathogen, we have open fracture wound. In case of open fracture, there is no specific pathogen. It mostly be polymicrobial. So we'll need Ali will discuss the antibiotics, but most likely will be a broad spectrum. This is for the open fracture. And in case of surgery, we have either cut contamination during surgery, or sometimes during the joint replacement, the joint itself can be contaminated. And this, in this case, we have the most common organism that causes this, which is the Staph epidermidis, which is a normal pathogen in the skin flora. And the third and final type, we have the vascular or neural insufficiency. Abdullah explain why these are considered a cause of osteomyelitis, but the most common type for this the vascular and neurological insufficiency is the diabetic foot ulcer. This is for the how does the infection spread. Now, what actually happens in osteomyelitis? Before I start, I would like to explain something. We have something here which is called the transphysial vessels. These the transphysial vessels are connecting the metaphysis into with the epiphysis of long bones. These vessels are only present in adults and infants less than 18 months. So in case of adults, if we have infection of in the metaphysis of long bone, this infection can be spread into the epiphysis, eventually to the joint through the transphysial vessels. However, in children who are above than 18 months and skeletally immature, they don't have the transphysial vessels, so the infection will be only confined into the metaphysis of the long bone. So the pathogen mainly comes through the hematogenous spread through the metaphysial vessels, then implanted inside the bone. We have acute suppurative inflammation, and we know that the end result with the inflammation, tissue necrosis, and dead pathogen with also dead neutrophils collectively together, we call it abscess. So we will have a intraosseal abscess. This the intraosseous abscess can pressure the metaphysial vessels and block it. However, this will not lead to ischemic necrosis. We have because we have another type of vessels which called the periosteal vessels that will cover this area instead of metaphysial. So the intraosseous abscess can elevate the intraosseal pressure. This eventually lead to the cortex rupture, the cortex of the bone rupture due to increase intraosseal pressure. The rupture of cortical bone, of the cortex of the bone, we call it cloaca, and this will allow the abscess to drain from the intraosseal space into the subperiosteal space. Also, and sometimes the periosteum itself can perforate, the abscess can perforate the periosteum, and will have a soft tissue abscess, and sometimes even perforate the soft tissue and directly drain into the skin. In that case, we call it a sinus tract, and also it can occur in both acute and chronic osteomyelitis. So in chronic osteomyelitis, we said the abscess will block the metaphyseal vessels. In chronic, the subperiosteal abscess will also block the periosteal vessels. So this will lead to ischemic necrosis of the bone, we have chunk of necrotic bone. We call it sequestrum. The problem with the sequestrum, it's the bone itself. It can work as a source of infection, and also the pathogen can use it or use it as a protection against antibiotics. So that's why in chronic osteomyelitis, it's very difficult to treat with antibiotics only, and there is high chance of recurrence. And this necrotic bone, we will have a reactive new bone formation. This new bone formation, we call it involucrum, and indication of the chronic inflammation, which we know that it has both inflammation and healing occurring at the same time. So this is for pathophysiology. Thank you everyone for listening, and I hope you enjoy the rest of the seminar. Now move to Abdullah.
تسلم يا سلمان. ارجع بس للصورة اللي قبل شوي.
سم
عبد الله العريني الحين متقدم. ها دقيقة. طيب بالنسبة للصورة اللي قبل شوي، دقيقة بس. وين عبد الله؟ مين اللي بيقدم بعدك؟ سلمان.
عبد الله العريني. عبد الله العريني.
يلا. طيب بالنسبة للصورة اللي قبل شوي، عندكم طال عمرك اللي هو عندكم ترانسفيزيال فيسلز، وقال لكم سلمان مشكورا انه هذه في التشيلدرن اقل من 18 شهر ممكن انها تنتقل الى الجوينت وتسبب لك سبتيك ارثرايتس. هذه من الاشياء اللي تلخبطنا في الاورثوبيديك. ازت اوستيومايلايتس ولا سبتيك ارثرايتس؟ زين. متى؟ لانه يختلف العلاج في كل واحده منهم. If it is septic arthritis, we have to do a surgery, irrigation, arthrotomy for the joint immediately. If it is osteomyelitis, the treatment usually with the antibiotic, unless there is abscess formation ولا sequestrum ولا involucrum. Osteomyelitis usually treated by medicine unless there is a pus collection or there is septic arthritis. هذا بالنسبة طبعا السكوسترم عارفين انه ديد بون، والانفوليكرم نيو بون فورميشن. طبعا حالات الاوستيومايلايتس very bad and very difficult to treat. The commonest organism غالبا في كل الاحوال هو الستاف. ترى حتى لو قال لك انه فيه بعضها يقول لك epidermidis وما ادري ايش. Usually the staph is the predominant and usually we treat the staph with the first generation cephalosporin. السلام اللي بعده يلا.
Okay, my voice clear?
صوتك مو واضح. لا
الحين
شكلك تستخدم مايك الكمبيوتر.
لا يسمع لكن
شوف الاعدادات يمكن.
الآن واضح الصوت؟
واضح عبد الله.
Okay, thank you Salman for the introduction. My name is Abdullah Areni. I will continue with the classification of osteomyelitis. I have two major classifications. There's the low and vulgar classification, which is actually the traditional classification according to the duration and the mechanism of infection. And then I have the Cherny-Madder classification, which is an important one for the management of osteomyelitis. I will start with the low and well-model classification. First, the classification according to the duration of infection. It could be acute or chronic. Acute if it's less than 2 to 3 weeks, and mostly it is hematogenous. Actually, if we said acute, we will think about the infection in children, and we will, when we say children, we will think about the hematogenous growth. Other than that, will be considered non-hematogenous, mostly, for example, the trauma. Uh, for the chronic type, we have chronic suburative and chronic specific, specific for a specific cause and a specific features like TB, osteomyelitis, or skeletal syphilis. For the chronic suburative, it could be non-specific. And also we have body abscess, which actually I found it in some books that it is wrote in a subacute classification of osteomyelitis. It is the most common form of it. It is a chronic infection, but lack the systemic manifestation, and mostly seen in patients with a strong immune system. Uh, for the other part of the classification, which is the mechanism of infection, this is actually the pathophysiology, which my colleague Salman explained. I will not replay, but I will add that the acute hematogenous type, it is the most common osteomyelitis, and as it affects mostly children because of the rich blood supply to the metastasis of lung bones. So I will move to the second classification, which is the Cherny-Madden classification, based on the anatomical position and the physiological status. It is very important for the management of the cases. First, the anatomical type. We have 4 stages according to the portion of the bone that is affected. So we have in stage 1, medullary osteomyelitis, confined to the medullary cavity only, and must be seen in the hematogenous type. We have in stage 2, the superficial osteomyelitis to the superficial bone. Then we have stage 3, which is the localized osteomyelitis. It affects the full thickness of the cortex, but it is in a local area and can be easily removed. And the bone is still stable. This is very important because in stage 4, the diffuse osteomyelitis, we have loss of bone stability. It could be before or after the surgery, after the debridement. Then we have the physiologic class of the physiological status. We have A host, who is a normal host with no comorbidities. We have B host, who could be who is a compromised patient, could have a systemic, could be a systemic compromise or locally compromised. The systemic compromise mostly there is his immune system compromised, so he may have a chronic systemic disease like diabetes mellitus or kidney failure. Also, he may have immunosuppressive therapy or HIV, and there are other examples. For the local compromised patient, he has compromised vascularity. So we'll see it in patients with arterial disease or venous diseases, scarring, or even smoking considered local compromise. For the C host, who is a patient that's untreatable for the infection itself, the treatment is worse than the disease. So there is no quality of life improvement if the infection is cured, and the morbidity of the procedure itself exceeds that of the disease. Mostly these patients will think can be patient. This is what I have for the classification. Now my colleague Rupan will continue.
طيب ثانك يو عبد الله. الصوت واضح يا اخوان؟
نعم واضح.
واضح.
طيب starting with the clinical presentation, but first we must ask ourselves what are the factors or contributing factors for the severity of the disease. Well, after reading, there is mostly two factors which are which are the M and the M, double M. The first factor is called the man or the host, which are depending the age of the host and medical condition. The age of the host, mostly in children, we have acute osteomyelitis, and the site of the affected bone will be in the arm or the leg bones. Whereas in adults, we have acute or chronic osteomyelitis. The sites are the pelvis, vertebrae of the spine, or feet. The feet mostly in the diabetic patient. The second subfactor is the medical condition. As my colleague Abdullah just mentioned it, having risk factors will make you more prone to chronic osteomyelitis, which characterized by persistency and recurrence despite the treatment. Actually, we can add the third factor after my colleague Salman described it, which is the skeletal maturity. And already described and discussed in details. The other M, it's called the microbe, mostly bacterial, and in fungal, mostly in immunocompromised patients, and mostly will be aggressive. We have also viral infection. All of these microbes will cause osteomyelitis. Actually, my colleagues touched this subject and briefly, but I want to emphasize on this. Okay, moving in the detailed description of the clinical presentation. Let's start with the breakdown of the term osteomyelitis. As you can see, osteomyel, it's referred to the bone and the bone marrow. Itis is referred to the inflammation. So it's inflammation of the bone and its marrow. Inflammation we have, as you all know, we have two types, either acute or chronic. Acute mostly in children, and the sudden duration. And its character with the high fever, and that fever will have adjacent symptoms like chills, night sweating, and rigors. In the acute, we have 5 cardinal signs. As you all know from the basic years, these are the pain, which called in this case the ostalgia. We have also the vasodilatation of adjacent arteries. We have heat, redness. The increased permeability will cause swelling, and the swelling, if it involves the joint, we have loss of function of that joint. Early in the loss of function stages, before the loss of function of the joint, we may have the painful movement and sterile effusion. As a complication, it may progress to the secondary septic arthritis. If this case left untreated or poor medical treatment, we will have the chronic stage. There will be exaggeration of the acute symptoms, and we will have the signs of chronic, mostly chronic, which are, if you see the patient bone involved in the osteomyelitis, you will see as irregular bone thickening under the skin. And the skin also may be perforated by the sinuses. And the sinuses, as you can see in this picture, drain the inside or intraosseous abscesses and maybe multiple sinuses. The sinus will discharge, this discharge will contain the bony spicules and the pus. Also, we have scar, obvious as it chronic inflammation, and we will have the muscular contracture. After the contracture, we'll have deformity and decreased movement if it involves the joints, adjacent joints. As a complication, we have the pathological fracture. Okay, this slide, just for clearance, we have something called hematogenous osteomyelitis, as my colleague Salman described it. The associated symptoms will be as acute systemic illnesses like malaise, fever, chills, leukocytosis, especially in bacterial, and marked throbbing pain over the affected region. The bone is highly vascular and highly innervated. That's why these symptoms are mostly acute. May subtile, the symptoms may subtile, like in the unexplained fever in infant, just an unexplained fever in infant, and we may have the local pain in adults, early in stages, of course. You must know that most of these symptoms are listed, or I just talk about, they are non-specific symptoms, like fever, fatigue, malaise, lethargy, night sweat, or irritability. Irritability, mostly in infant, because the infant cannot express pain or told you there is a pain in the, so it will be irritable for him to touch the affected site. Non-specific symptoms, of course, required a specific and long diagnosis, which will be discussed by my colleague, Dr. Ali Al-Mini'. So thank you all for your listening, and leave you with Dr. Ali.
Thank you, Irfan. Doctor, can you make a presenter?
ارفع يدك علي تكفى علشان تطلع لي.
Okay, Bismillahirrahmanirrahim. My name is Ali Al-Mini', and I will discuss the remaining part, which is concerned about the diagnosis and the management of osteomyelitis. After suspicion of osteomyelitis in a patient, we'll start the workup diagnosis that include studies, labs, and biopsies. Let's start by the lab work. First thing we'll take is a blood culture, which need to be taken quickly before the empirical antibiotic treatment, or at least in a 48 hour after starting the empirical treatment, if it's have been given, and to avoid any false negative results that could complicate the osteomyelitis further. The second lab study that we will use is white blood cell count and differential that may show leukocytosis depending on the stage of osteomyelitis. Anemia, as a result, can be seen as a consequence of chronic osteomyelitis, as anemia of chronic inflammatory disease, or can help us in giving the antibiotics if the patient is have a sickle cell disease. We may suspect specific organisms that can cause osteomyelitis in this population. ESR and the C-reactive protein are very good to test, but although they are very sensitive, but not specific for osteomyelitis. Alkaline phosphatase may be taken if there is suspicion of malignancy, since the alkaline phosphatase can be seen increase in malignancy situations, but they are normal in the cases of osteomyelitis. This is what about the lab test. The second thing is the imaging studies. Important to know that early stage of osteomyelitis, acute osteomyelitis, there's no radiological studies can show detected a very early stage. Although when we talk about the MRI now, we'll talk what's special about it. Let's start by the radiographs X-ray that may show edema and metaphyseal refraction, but also both are late. Even the early, we mean early, not less than 1 week. And periosteal new bone formation can appear in the end of the first week after the onset of osteomyelitis. Other features that can be seen in X-ray appear mostly after many days. MRI examination is the most sensitive diagnostic study. Why? Because it can show the signs of inflammation in 5 or even less days of the onset of infection. So starting the prompt antibiotics empirical, or if have been taken the biopsy, we can start definitive pathogen-directed antibiotics. And also it's the key to evaluate any abscess in the osteomyelitis. CT scan can be asked in specific situations, for example, if there is a presence of a fracture, if the osteomyelitis is caused by, for example, open fracture. Here's an example of a radiograph X-ray. We can see here the sclerotic wall with a radiolucent lumen that may show abscess, caused by abscess. This is a stage, but it's not early stage. So the diagnosis by X-ray is not very early. Early stage can show only edema and periosteal inflammation lately. Now the biopsy, which is the confirmatory test, the most sensitive and specific test, because we are taking the biopsy from the suspected side and we examine it to find either the histopathology, the osteonecrosis, and the inflammatory process. And also can be used, the biopsy can be used to culture and identify the specific organism. So the biopsy should be performed whenever it's possible. It's the best way to start the specific antibiotic, and because antibiotic in osteomyelitis save lives. So start early, and found out that the results are false positive, better than found out that the results are false and negative. Now start the management, the end of the story, and we hope it's a happy end. The management, we will start by the conservative choice, unless we have indication of surgery that we will say right now. Conservative bed rest, embolization of the affected extremity is very important. Antibiotic treatment, we'll start by empirical antibiotic if we couldn't obtain the biopsy very early. And the empirical will depend on the age of the patient, if the patient have any prosthesis in the affected site, and any other medical conditions that force us to change our choice of antibiotic. After the results of culture and sensitivity, definitive antibiotic treatment also will be started. Very important to say that empirical therapy is IV, and the oral shift can be determined depending on the future results. Here we have two schedules. The above, we have the initial antibiotic treatment, and we can see it's depending on the age of the patient. In adult, we start by IV vancomycin plus any anti-pseudomonal agent, either cephalosporin or from the fluoroquinolones. For example, we could give IV vancomycin with ceftazidime as the empirical therapy. In children, we have divided them into less than 3 months or more than 3 months. And for each, we will give a specific antibiotic that could not cause harmful risk factor, harmful side effects depending on their age. After the result of the biopsy and culture and sensitivity, we start the definitive antibiotic treatment. Here we have the methicillin susceptible Staphylococcus aureus. We could give the anti-Staphylococcus penicillin, like IV nafcillin or oxacillin, first or second generation. Or the first or second generation of cephalosporins. IV vancomycin is given if the result shows MRSA or Staphylococcus epidermidis. There is a special cases where the patient have prosthetic joints. Whenever we have the patient with the prosthetic joints, we should have rifampicin with the antibiotic that we'll give depending on the culture and sensitivity. But rifampicin should be added whenever we have a prosthesis that involve the osteomyelitis. Here, the surgical choice, which is indicated in some situations, like when you have a refractory case of osteomyelitis. We can identify a refractory case that not respond or not improving with antibiotic treatment. And if presence of any abscess, we need to drain the abscess to give a better result of the antibiotic. Post-traumatic osteomyelitis, we need debridement and fracture management. Infected prosthetics should be removed or presence of any foreign body. In peripheral artery disease, we may go to the surgical choice to vascularize the wound area. In follow-up of our treatment, we could use the CRP, C-reactive protein, to measure to measure any improvement. So the decline in the C-reactive protein may helpful in follow-up of the osteomyelitis treatment. If there's failure of decline in a 3 days, that this will prompt us to change the treatment. All for any reason, although maybe the results are false, or the treatment is, or the organism is resistible to the antibiotic choice. Antibiotics should be continued until the ESR or CRP, more specifically because CRP changed every 2 days, until it returns to its normal levels, usually between 4 to 6 weeks. Although more than 6 weeks, maybe continued more than 6 weeks, depending on the situation. And adding the surgical choice to our plan. Thank you very much. These all our resources, all the guys. Thank you.
شكرا جزيلا للجميع. طبعا for follow up your patients, you have to evaluate the patient clinically and radiologically and through the investigation. Clinically, the symptoms, it will disappear, the fever and malaise and other things, non-specific symptoms. And radiologically, it will take time to improve. The other things, the lab workup, the CBC, the WBC, ESR, and CRB, it will decline. Usually, we expect the CRB, it will decline within every 2 days, and the ESR usually it will take 2 to 3 weeks. أتمنى إنه كل شيء واضح. إذا في أي ملاحظة تفضلوا بالسؤال.
دكتور، أنا عندي سؤال بخصوص الباثوفيزيولوجي.
تفضل.
لأني أنا صراحة عانيت، لأني كل سورس ألقاه مختلف تماما عن الثاني. بعضه حاط لي الباثوجينيسيس مكان الباثوفيزيولوجي، فما في طريق نحدد عشان إذا كان اللي بعدي عندهم سيمينار باثوفيزيولوجي يقدرون يحددون. تسهل عليهم.
وبالعكس أنت شرحتها بطريقة مرة ممتازة، يعني إنه كان من ضمن شرحك البلد سبلاي وكيف الفرق بينه وبين الادلت والبيدياتريك، وبعدها قلت انه ممكن يعمل لنا ديد بون، وبعدها نيو بون فورميشن، وبعدها ممكن it will extrude through the skin. يعني كويس الشرح، ما كان في ملاحظة. طبعا في النهاية هذا يكفي عليها طبعا as a pathogenesis وباثوفيسيولوجي. تفاصيل كثيرة في الباثوفيسيولوجي وهذا الجينيسيس doesn't make difference for us. بالنهاية أنت بتعالج المريض as a conservative with antibiotic. If there is a pus or indication for surgery, pus collection, neurovascular compromise, extension to the needle joint, ذيك الساعة تقول والله surgical intervention.
شكرا لك دكتور.